Excuse me, sir, come on up and I'll ring you out. Come on, buddy, we're out of here at 5 on Sundays. Yeah, hey, this is Joe over at Fairfax Auto on Church. Yeah, I got a problem getting someone out of here. He's over there. I don't know what he's on, he's mumbling, but he just won't leave.
Okay, buddy, it's time to go. The store's closing.
Bye.
Come on, it's time to go.
What's your problem?
If you had left when we told you to, you wouldn't be on the floor. Get him out of here.
You go to put your hands on him, and he goes, flails about, and now you've got a bottle breaking over somebody's head, and the police aren't trained to back off and say, oh, okay, we'll let you start flailing about and assaulting us. We're not trained to do that.
Come on, it's time to go.
What's your problem?
Being attacked may be a cop's worst fear, and the response must be decisive. But did it need to come to this?
We just saw a horrible scene. I'd like to ask you whether it was realistic and whether this could happen in real life or whether it does happen in real life.
That could happen.
It does happen.
Yeah, from time to time, I would say.
What normally happens when you get on the scene like this? Do you have a standard protocol of handling it?
Usually you arrive and you try to figure out what's going on. Observe the scene, observe the person, try to determine if it's a medical emergency, if it's criminal, or if there's another reason why they're just standing inside the business and not leaving.
How do you try to tell whether it is medical emergency and whether it is your role to deal with it or whether you need to call in EMS?
Well, our role is to arrive on the scene, determine what is occurring, try to get the factors, get all the critical information we can. If there's family members around, we try to ask questions and they can give us information. We look for the medical alert bracelets. Once we determine that medical aid is needed, then we request through dispatch and they'll send ambulance to the scene and then they take over from there. And of course, if there's any criminal element to it, then we will deal with that at a later date.
Right. How do you think, Mike, the situation could have been handled differently in this particular scene?
You could not rush in. You could sit back and observe and see what's going on with the person. In this particular instance, he was wearing a medical alert bracelet, so that could be a clue that a medical emergency is occurring and it's not criminal.
Or you could also give more verbal commands, ask more questions verbally before actually getting closer. That way it gives you a better opportunity to realize exactly what you have. Give you a better chance to get an overall look at the picture itself.
Constance, you made a point before we started shooting that there was an initial physical contact by the female officer. Would you mind talking about that?
I think after viewing the video, she did not take enough time to assess the situation and she put her hands on him, which immediately caused him to push her, and then he assaulted the officer with the bottle. All of that could have been alleviated by them standing back a minute to try to determine how long he had been there, kind of observe his actions, and try to talk to him before touching him.
That is an excellent point. Patients with seizures are very, very rarely spontaneously aggressive. Very, very rarely. So you, in your role as a police officer, you have to prevent aggression and physical violence. That's extremely rare in the middle of a seizure. So you do have the opportunity to stand back, just like you said, and watch. Anything else, Joe, that you think could have been done differently?
Better communication between the two officers. More questions should have been asked of the gentleman there. Mm-hmm. How are you feeling? What's going on? Do you know what day of the week it is? Why are you here? More questions versus just walking up and putting your hands on someone. As a police officer, we don't want to put our hands on someone. That's the last thing we want to do.
Yeah, that's a good point. And we saw that the gentleman was completely disengaged. He was unaware of the environment. He was unaware of both the cashier and of the police officers walking up to him. He was in his own world. So that's a good point. So observe, take the scene into consideration, see what clues you can see around, and wait a little time to see how things will evolve. Is that a fair way of putting it?
Absolutely.
That's right.
Yes, it is.
Do you have any questions for me?
I do, doctor. My question to you is, when we first arrive on the scene, sometimes we don't have a lot of time to assess whether it's a medical necessity or if somebody's on drug. Can you give us 3 to 4 critical factors that we can look for to see if someone is having a seizure versus if they're on drugs?
Thank you. That's a very good question. So I think the first point is the violence. If the person is not violent, I think you have time to observe. And I think observation and taking time is critical. Seizures usually last 1, 2, 3 minutes. It's not common that they last longer than that. So if the person is not violent, and like I said before, during seizure they very, very rarely are, unless they are physically approached, as happened in this particular case, then you have the time to stand back and watch.
Okay.
Physical approach can trigger the aggression, as happened with this gentleman. So that's exactly the wrong thing to do, as you pointed out earlier. Stand back and watch. It may be very difficult to distinguish drug-related psychosis, if you like, from medication-related similar state of consciousness, altered consciousness. Both can affect the same part of the brain and result in the same behavior. So PCP can do it chemically, seizure does it electrically, but they may affect the same part of the brain, resulting in the same behavior. But there may be some distinguishing features. In this video, one of the things that we saw was the repetitive movement of the index finger, tapping the bottle. The gentleman was doing that all the time, and he was looking around confusedly, and he was smacking his lips. Involuntary movements like that are relatively common with seizures, with focal seizures of temporal lobe focus. They do not occur with psychosis due to drugs. So that's a very useful distinguishing feature. I mentioned the violence, which it's not common with seizures unless the person is physically approached. And then the duration. The seizure will last the 1, 2, 3 minutes and then stop. The patient, or the person rather, may still be confused after the seizure, but you'll see that there is a change, there's a reconnection. This gentleman was completely disengaged from the world. He was unaware of the cashier, he's unaware of the police officers. He was just, as you had put it early on, with the 1,000-mile stare,
Yes.
out of reality. A person with a seizure may be in that state for that 1 or 2 or 3 minutes, but then they will click back. They will see the environment, they may still be confused, but oftentimes you're able to perceive the change. So standing back and observation is the critical thing. And then watch for surrounding clues, like you said, Mike. The gentleman has a bracelet on his arm. It's something that you should see when you approach him, or if it's a lady, her. So the involuntary movements, lack of aggression, duration. Many of the other things may be very similar between drug-related change of consciousness and seizure-related change of consciousness. Does that answer the question?
Yes, it does. Thank you.
Now, doctor, you touched on it a little bit. We deal with drugs, mostly PCP. And PCP and seizures typically they look similar. Is there any way to tell the difference between them immediately?
I think these involuntary movements that I mentioned are highly unlikely to be present in PCP. Second thing, if you've got spontaneous aggression, it's highly unlikely to be seizures. And third, the duration. PCP will continue. Seizure will usually stop after a couple of minutes. Not invariably. You may have situations where seizures and continued alteration of consciousness may last for minutes or hours, but it's uncommon. Those would be 3 of possible features that might help you to make the distinction.
Thank you.
Now, Dr. Klein, it's kind of interesting. I mean, how about other mental health issues such as Alzheimer's or dementia? You know, they similar to what we saw in this episode here. You know, how would we differ between those two?
You're right, they can be similar. So one distinguishing feature which is common, not invariable, is the age. Dementia is relatively unlikely to happen in a young gentleman like this. It's much more likely to happen in an older person. A person with dementia may be confused, they may be talking no sense, they may be agitated, sometimes they may even be violent, but they will engage you. If you talk to them, if you look at them, they will look back at you and they will talk back at you. They may talk in a totally inappropriate way. You may say A and they may answer with Z, but they will engage with you. As we saw with the gentleman in the video, he did not engage. A person with seizure will often not engage. So that's one distinguishing feature which, like all things, is not invariable but may help.
So we should ask more questions.
Correct.
Take our time,
Ask the
slow
question,
it down.
have the space between you and the person, watch them, ask questions in a non-confrontational manner so as not to make them feel threatened.
Dr. Klein, I do have one last question. How can we differentiate between someone having a diabetic shock or if they're having a seizure? What are the symptoms that we can look for in those situations?
Thank you. That's also a very good question. So diabetic shock is dangerous for the person. It is not dangerous for you all. It's very unlikely that a person in diabetic shock, which is due to very low blood sugar, would strike out. They will be in a process of of fainting, if you like. When you have low blood sugar, the body doesn't have enough energy to perform its function, the brain doesn't have enough energy to perform its function, and it gradually shuts down, just like with a faint. So the person will gradually fade out, they may feel faint, they may look pale, they may look sweaty, because in response to the low blood sugar, the autonomic nervous system kicks in and causes these things. They may start being disengaging, and then they may faint. And it's not at all likely that they would be aggressive, and it's not at all likely that they would be withdrawn in this fashion.
Okay.
Does that answer the question?
Yes. For an example, I had a traffic stop with somebody that refused to stop, which would be considered a pursuit. They were having a diabetic issue, and I didn't realize that until I got them stopped and pulled them out of the car, because I'm assuming a part of it is your brain's not functioning properly, you're kind of disoriented.
That is absolutely correct.
Obviously,
yeah.
they couldn't hear the lights and siren or see me behind them. Is that one of the factors?
That is correct.
So if you're
yes.
giving them commands or anything, they're just not really hearing anything?
That's right. Yeah.
Okay.
Well, I'd really like to thank you again for being here this morning, for taking an interest in the issue and taking the time to talk about it. Thank you again. And
thank you.
And please, when you are in a situation like that, remember that it could be medical and that it could be a seizure. Thank you again.
Thank you.
Thank you, doctor.